Welcome everyone to this Flen Health Facebook watch party. My name is Samantha Bostock and I'm a therapeutic radiographer. I'm really excited to be joining you this evening to talk about radiotherapy. And if you haven't seen one of our previous watch parties, then I'll explain what it's all about. I've pre-recorded a presentation for you and we all watch it together and chat about it in the comments. I'll be answering your questions and joining in the conversation throughout the presentation, so please don't be shy, type in any questions you have and I'll answer as many as I possibly can. Thank you Flen Health for putting this event on this evening. Flen still have a number of hand hygiene tools to give away to staff who would find them helpful, and you'll be able to find out more about this at the end, so it's definitely worth staying around until the end. So, welcome to my presentation. My name's Samantha and I've been a therapy radiographer for 25 years and I lead the on-treatment review service at Gloucestershire Oncology Centre. We're a team of specially trained therapy radiographers who support patients throughout their radiotherapy journey. So we will see patients regularly within the review clinic to review, assess and manage their radiotherapy side effects. We will use prescribing where necessary and also offer lots of advice and support, whilst also referring to our nursing or AHP colleagues as we need to. We will also offer psychological and emotional support to patients and liaise with community services to ensure there's continuity of care for our patients. I've recently been appointed to set up our late effects service, so that's another exciting aspect of a therapy radiographer job. So I'm looking forward to reading your comments and answering your questions as we go through tonight. So the aims of the presentation, I want to talk to you a little bit about what is radiotherapy and who are we, who are therapy radiographers. And we'll look at some of the side effects of radiotherapy and then more specifically about skin reactions. So radiotherapy itself is the use of high energy radiation to damage cancer cells. These high energy X-rays will penetrate the body and collide with the cells within the area of the body being treated. And at that point, secondary electrons will cause potentially fatal damage to the cancer cell DNA as it divides. The treatment units that we use to deliver radiotherapy to our patients are called linear accelerators or LINACs, and you can see from the photo on the screen now that these are quite large pieces of equipment which patients can find quite daunting to start with. The radiotherapy treatment machine itself rotates around a fixed point in space called an isocenter, and the patient will lie on the treatment couch in a reproducible position. So we will position that patient so that the area that we're treating is situated at the isocenter, and then the LINAC will rotate through 360 degrees, delivering the radiotherapy from either specific angles or as a continuous arc of treatment. So for patients, there's nothing to see or feel during their radiotherapy, but they are in the treatment room on their own. So we go outside to actually switch the treatment machine on, but we can see our patients all the time and we can communicate with them over the intercom system. So therapy radiographers, we are allied healthcare professionals. We undergo a 3-year undergraduate degree, and following qualification we can then continue to study at master's or PhD level. We're registered allied healthcare professionals with the HCPC, and we support and follow our patients all the way through the radiotherapy journey. So prior to starting treatment, patients may well come up to a clinic to meet us so that we can talk them through what will happen during their treatment. They will have a CT scan which localises the area of the body that we wish to treat, and we may well need to make immobilisation devices in order for the patient to keep still at every single treatment. We use very advanced computer planning systems to then plan individualised treatment. Therapy radiographers will then deliver the radiotherapy to the patient at each visit. We will also manage their radiotherapy side effects and offer psychological support. There are lots of opportunities for therapy radiographers in advanced practice. We have consultant radiographer roles, on treatment review roles, and we can now qualify as non-medical prescribers. We get involved in research, late effects services, and image review. We are also involved post-radiotherapy in acute and long-term follow-up of our patients. So I think we all recognise that radiotherapy patients can experience some side effects, but just to let you know what we as radiographers do, we are very much about patient-centred care and supporting the patient holistically throughout their journey. We will initially assess the patients and stratify them according to their risk and their likelihood to develop radiotherapy side effects. And we offer advice and support, both practical and psychological, throughout their treatment. And this is done in the way of an on-treatment and assessment review clinics. So we will help patients manage their side effects during their treatment, but also this continues after they've finished with us, as I said, liaising in the community to make sure that the patient have all the support and services that they require. So radiotherapy side effects are site-specific and very dependent on the area of the body that we're treating. So if we were treating a patient for breast cancer, we wouldn't expect them to then experience diarrhoea because we're not treating any of the abdominal area. And there are several influencing factors when we're talking about radiotherapy side effects. And some of these are intrinsic, so patient dependent, such as age. And we know that as patients get older, they may be more likely to experience side effects. Smoking is a big factor. If patients smoke, we know their side effects are generally more severe. If patients are obese or if they have coexisting disease, such as diabetes or cardiovascular disease. Other radiotherapy side effects are extrinsically based, so treatment related, and these are to do with the dose the patient's receiving. So the higher dose of radiotherapy, the more likelihood there is of side effects. The bigger volume that we're treating, again, more side effects. And also fractionation, which is how we divide the total amount of radiotherapy a patient is to receive into daily doses. And from a palliative point of view, we may give radiotherapy in a single fraction, and from a more curative point of view, anything from 3 weeks up to 8 weeks on a daily basis. And palliative radiotherapy and curative radiotherapy will have very different side effects. The site of the body, if we're treating the pelvis, you would expect pelvic side effects. If we're treating another part of the body, you wouldn't. Beam energy, we can deliver radiotherapy with a variety of beam energies, so we can treat either deeply within the body or more superficially. And if patients are undergoing concurrent treatments such as chemotherapy, they may find that their radiotherapy side effects are worse, and this is because often chemotherapy is given as a radiosensitizer to make the radiotherapy more effective. There is always a delay in the start of side effects, so we would expect the initial side effects to show themselves usually around 7 to 10 days after a patient begins their course of treatment, and these will then build up gradually over the course of their radiotherapy, peaking usually 2 weeks after their treatment finishes before they then gradually start to settle, which can take another 4 to 6 weeks dependent on the severity of the side effect. And what kind of side effect the patients experience. So it's really important that we're warning and preparing our patients for that, so that they don't believe that when they stop the radiotherapy, their side effects will just go away the next day. And it's important that that continued care is available. Radiotherapy related fatigue is the one side effect that isn't site specific, but can affect anybody having radiotherapy regardless of their age, where we're treating, whether it's a curative or palliative intent. So it's very, very individual. And some patients find they report just feeling a little bit more weary than normal, a bit more tired, but can carry on all of their normal activities. Other patients are really debilitated by fatigue and it stops them functioning, they can't work, and it really has an impact on their quality of life. And it can carry on not just for a few weeks after radiotherapy finishes, but months and maybe even years. And in that instance, these patients need an awful lot more support. There are some predisposing factors, such as if patients have already gone through previous chemotherapy, and sometimes if they have coexisting health issues as well. So radiotherapy radiographers will offer advice, will give written information, we'll talk to our patients about their diet, so having a well-balanced nutritional intake, and we don't advocate cutting out any particular food groups at all. We encourage exercise or activity depending on what the patient's normal is before they started coming through this journey, and encourage them to keep up as much activity or exercise as they can do within their limits. We will offer support, reassurance that actually this is a really common side effect, and although it's not normal for that patient, it's something that we do see an awful lot. We encourage pacing, so keeping a journal so the patient can identify when during the day or the week they might find they have more energy and are more able to do the things that they either need to do or that they enjoy, and at those times when they do feel more fatigued, then they can rest and conserve their energy. A lot of our patients continue working during their treatment, so it may be if they're struggling with fatigue, we need to talk to them a little bit about whether they can reduce their hours or alter their ways of working, maybe work from home, but also taking into account that actually this might have a financial impact on the patient, which needs addressing as well. We work on sleep hygiene, a lot of which is relatively common sense, but sometimes we just need to point this out to the patient that actually no computer screens, phones in the bedroom, making sure that their room is dark and an appropriate temperature, use of lavender oil and that kind of thing. But we'll also refer to our AHP colleagues, such as dietitians, to talk about nutritional intake. Occupational therapists and physiotherapists often run fatigue management courses, which are absolutely essential to support these patients throughout this time. So moving on now to more specific areas of the body and just touching on breast radiotherapy side effects. So these patients can really expect some kind of skin reaction, and this can range from very, very mild and minor to something a bit more severe, particularly in the inframammary fold and the axilla, which are skin folds where the area gets warm and there's more friction. And also for patients who've had a mastectomy, we deliver radiotherapy to a mastectomy site planned so that the highest dose of treatment is more on the skin surface where the surgery was and where the scar is, whereas with breast radiotherapy, the dose of radiotherapy is higher actually within the breast tissue. Patients can get a sore throat if their supraclavicular fossa is being treated, and this we would do if they had positive axillary lymph nodes surgery. But often patients don't really expect to get a sore throat because we're treating their breast area, so it's important that we warn them about that at the start. And also some breast swelling, maybe some tenderness and shooting sensations. Head and neck radiotherapy side effects can be quite severe and can be very debilitating for patients because they're very obvious, they're very on show, and they affect communication, our appearance, speaking, eating, absolutely every aspect of life. So they can experience very severe side effects. They often get oral mucositis, which can be very painful, and we grade this according to the WHO oral mucositis grading criteria and manage that accordingly with various products. They can experience xerostomia, dry mouth, which can lead to a risk of infection and also difficulty with eating, drinking, that kind of thing. And also on the back of having a dry mouth, any saliva that they do produce can be really, really thickened and very, very difficult to shift, and that production can be quite excessive. Patients may develop oral candida, which we'll manage using appropriate antifungal medication. And difficulty swallowing, difficulty eating as well. Now, most of our head and neck patients already have a PEG tube fitted before their treatment starts so that we can maintain an adequate nutritional intake. And since we've been doing that, we've found that patients do cope with the radiotherapy an awful lot better because they have that energy that their body needs to recover from the treatment. Up until we started putting pegs in our patients, we did find that the majority of our head and neck patients were admitted to our inpatient setting towards the end of their radiotherapy. So using peg feeding from the start does mean that we can keep our patients out of hospital. Pelvic radiotherapy side effects very much depend on whether we're treating the prostate, bladder, colorectal tumours or gynae tumours, but generally patients will experience lower urinary tract symptoms such as burning on micturition, which may or may not be due to urinary tract infection. Often actually is due to the radiotherapy causing inflammation along the urinary tract. Frequency and difficulty of passing water can be very distressing for patients, so we need to make sure that they're not heading into retention and again manage that accordingly. As well as passing urine much more frequently, patients often find they have more of an inability to hold on to their urine and there's a huge sense of urgency. So we are very proactive with encouraging patients to carry out their pelvic floor exercises from at least the start of radiotherapy, if not even before. And Nocturia can be another really difficult side effect, because if patients are getting up every half an hour or hour at night, then their sleep pattern's disturbed, they're more tired during the daytime, and then they find it's much more difficult to cope with what they've got going on. Lower GI tract side effects can include altered bowel habits, which could be quite mild, ranging from just perhaps opening their bowels once or twice more a day, all the way through to quite severe diarrhoea, depending on the size of the treatment area that we're treating. Patients sometimes experience tenesmus, which is that feeling of needing to open your bowels when you don't really need to, because the lining of the rectum is inflamed and swollen, and that can lead to proctitis, which is painful and can sometimes lead to passing blood. Our patients often experience rectal mucus, which again can be quite distressing, because if patients are urinating or opening their bowels or even just passing wind, then often they can pass a substantial amount of rectal mucus at the same time, which can be quite distressing. Our gynae patients, as well as experiencing all of those side effects, can often experience vaginal soreness and dryness, and that can be a long-term side effect leading to fibrosis, so it's really important that that's identified and managed as patients go through their treatment. So now on just to talk in a little bit more detail about radiotherapy-induced skin reactions. We don't call these reactions burns because they're not burns in that the skin is affected from the outside, but radiotherapy is damaging the underlying layers of the skin. And also using the term burns to a patient can be quite emotive and quite distressing for patients as well. So these skin reactions can range from absolutely nothing and very mild erythema all the way through to quite a severe moist desquamation. And that will depend again on those factors that we talked about at the beginning of my presentation. Patients will often find that their skin is sore and it can be very itchy and can potentially be quite painful as well. There is a gradual build-up of a skin reaction. As I said, the damage is done from the radiation to the basal cell layer of the skin, and this gradually moves up towards the skin surface where it manifests itself as a skin reaction. But we're continuing to give radiotherapy, so that damage to those underlying layers is continuing to happen, and those cell layers still continue coming up to the surface, so you get the range from mild erythema to dry desquamation to moist desquamation. If we're treating skin folds, then the skin reactions are often much more severe due to the friction and the rubbing and the heat, and we often see this in the inframammary fold with our breast patients, the axilla, groin and anal areas, as well as I touched on earlier, mastectomy patients when we're treating the chest wall, as we plan the radiotherapy to give a higher dose to the skin surface. So here's a photograph of erythema, and this is in the inframammary fold, and you can see that that looks quite red, but the skin isn't actually broken at all, although at the lower half of the picture you can see it looks a little bit as if there's a rash, which may potentially be quite itchy. This is an image of dry desquamation, and you can see here that the top layer of skin is sloughed away, but again there isn't any exudate, and that due to the darker pigmentation of skin, the whole of the treatment field has actually gone really quite dark, and the skin looks quite fragile under there. And this is moving on to an area of moist desquamation, and you can see here that we've got erythema around the edges with some moist desquamation along the centre of the area there with some exudate, and that's going to be very sore with some exposed nerve endings and definitely needs us to input into managing that. After radiotherapy, patients can be left with various skin side effects such as telangiectasia, which you can see is quite obvious on this photograph. Patients can also be left with some fibrosis and some lymphedema as well. So it's really important that these things are discussed with patients from the outset so that they're aware of what might happen and also identified and supported as they go through their radiotherapy and afterwards. The Society and College of Radiographers have recently updated their guidance on radiotherapy skin reactions, and this is available for everybody to have a look at on the website on the screen, and we'll also be popping this in the comments so that you can have a look at it later on. They have carried out a systematic review of the available evidence and literature and produced guidelines as well as information for both patients and healthcare professionals, and these you can print off and also use as information leaflets to give to your patients if you need to. So they came up with 8 key principles which are really important, and that is identifying the patient's risk at the outset, looking at those intrinsic and extrinsic factors that we talked about a little while ago. Documenting the patient's current skincare regime and any other conditions that they might have which might put them at higher risk. So whether they already have eczema or psoriasis or other ongoing conditions. Using a standardised assessment tool to assess your patient and all of your patients, we use the Radiation Therapy and Oncology Group scoring system. It's important that all staff are trained thoroughly in assessing and managing skin reactions, so everybody's saying the same thing and managing patients in the same way. We need to audit our patients' reactions and collect data so that we can move on and learn from our experiences. And it's really important to empower patients to self-care and self-manage as well, so that they can take some kind of control over their experience and their progress as they go through treatment. The Society are very keen that we test new products within an RCT before we implement them, and that's absolutely right. Radiographers need to come up with more evidence-based research, but it is incredibly difficult to carry out an RCT on patients when you're wanting to try out products. So it is really difficult to come up with some of that evidence base. So the College of Radiographers have found that the evidence base isn't strong enough to either support or refute particular products or topical applications. And what's interesting in this update is the college are saying the evidence base isn't strong enough to refute particular products as well, so giving us a bit more leeway to try out new innovative products with our patients. They have recommended that all patients have a nutritionally well-balanced diet, that they moisturise the area that we're treating from the start, or if not before they start their radiotherapy, and this is to maintain integrity of the skin and also improves patient comfort and gives them something proactively to do as well. We don't recommend aqueous cream as a moisturiser and haven't done for many years, but it can be used to wash with, and we encourage our patients to wash and bathe the area that we're treating, whereas historically you may have found patients were told not to wash the treated area. Again, there's no evidence to say that they shouldn't. Patients can also use deodorant and swim during their radiotherapy, so long as the skin in the area is not broken at all. But what it's really important to do is avoid exposing their treated area to the sun, avoid friction as far as possible, so tight clothing that might rub, and definitely avoid adhesive tape within the treated area, because if you attach a dressing or anything with adhesive tape and then you remove that adhesive tape, you're going to remove that top layer of skin along with it. Patients are advised to avoid shaving and using cosmetics in the treated area too. But most importantly, we need to stop our patients from smoking, and smoking cessation is something that we really all need to be very proactive about to improve the patient's chances of having a positive outcome from their radiotherapy and reduce their severity of their side effects as well. So moving on to moist exclamation, I think it's really important that we stop concentrating quite so much on which creams our patients are using to moisturise from the beginning, because actually it doesn't matter what they use as long as they're keeping their skin in good condition. What we need to be concentrating on is how we decrease the severity and reduce the incidence of moist exclamation, and how we manage that once it happens. So we apply the principles of moist wound healing, which I'm sure that you're all familiar with. We need to use non-adhesive dressings because, as I just alluded to, if you use an adhesive dressing, once you remove it, you will be removing the patient's skin as well. And we need to avoid wound disturbance as much as possible to really try and encourage healing. So can we treat through any of these dressings that we're using? Is it really possible to promote healing while we're actually physically treating a patient? Sometimes I believe it is, and during my experiences, I've treated patients with moist exclamation and have actually seen signs of healing within the wound whilst they're still receiving radiotherapy. Patient comfort is obviously paramount, and we need to be considering pain relief both topically on the area of interest, but also using systemic analgesics to make sure the patient is fully covered from a pain point of view, and making sure that patients are compliant and taking their prescribed medication on a regular basis so that they have that constant level of pain control. Post-radiotherapy, it's really important that for these people with more severe side effects, we are contacting them post-treatment, either by telephone or allowing them to come back up to see us for assessments, and that we're liaising with their community services such as tissue viability nurses, practice nurses and community nurses for continued support with either dressings or monitoring. So the dressings and applications that we use, we're particularly keen on hydroactive colloid gels, which will protect and support skin regeneration. They're easy to apply for the patients themselves, so patients can self-care and be very proactive, and they don't necessarily require a secondary dressing on top. Sometimes we might use polymembranic dressings with a cleansing and analgesic effect, and sometimes these can be really, really helpful. They're also absorbent of any exudate. But again, we have that tricky situation of having to actually attach that dressing without causing further damage to the patient's skin. Sometimes silicone dressings are useful. They can be non-adherent, minimise trauma, and sometimes we can actually treat through them during the radiotherapy. What we can't do is treat through thicker dressings because the radiotherapy enters that dressing and acts as if that dressing is part of the patient, so then it will bring up that dose higher to the skin surface and actually alter the distribution within the tissue and make the skin reaction worse. Hydrogels can be very useful for de-sloughing, and also patients find them quite cooling and soothing, but again, we're talking about using an appropriate non-adhesive secondary dressing. Occasionally, hydrocolloid sheets may be useful. And also we sometimes use prophylactically barrier films or creams to try and reduce additional damage from friction, which may then impact on the patient's reaction in the slightly longer term. Some patients find they do really struggle with an itchy rash over the radiotherapy treatment area, and if that skin is intact, then we might sometimes use a 1% steroid cream just applied thinly twice a day. One of the most important things with all side effects and all patients going through radiotherapy is the support and the reassurance that we give them, and making sure they're aware that we can manage these side effects and maintain their comfort even if we can't actually prevent their side effects from happening. And as I said, pain control, absolutely important, and regular on-treatment review by our team of specially trained and qualified therapy radiographers. Psychological support is absolutely important. Patients will often find that their radiotherapy side effects are very, very similar to their presenting symptoms. So their first thought may be that their disease has come back, that their radiotherapy isn't working. So it's very, very important that patients are prepared. They have all the information they need to know what to expect as they go through, and also that we're reiterating that advice and support regularly during their radiotherapy treatment. In terms of late effects of skin, side effects of radiotherapy, very, very rarely patients may present months or years after treatment with a skin reaction, but more likely in the community you might encounter patients with some of the long-term complications such as the telangiectasia, fibrosis, lymphedema and even cellulitis, and it's really important that these are recognised as such and managed accordingly. And if you have patients with mild lymphedema, it's really important that they get referred into a specialist lymphedema service as soon as possible, because once we identify lymphedema we can manage that and prevent it from getting worse, but once it's taken hold and it's severe we can't actually make that any better, so early referrals are really, really important. So to end my presentation, it's really important that we are all encouraging patients to stop smoking, and I'd really like you all to take that away with you in order to improve their chances of having a positive outcome and reducing their severity of their side effects as we go through. Therapy radiographers are very much about patient-centred, supportive, holistic care. There is a need for more research to look at reducing the incidence of moist exclamation and improving its management. And I'd also like you to take away that therapy radiographers are really happy to offer help and support to all of our healthcare colleagues. So please, if you come across any radiotherapy patients and you need some help or advice, do contact your local radiotherapy department, because we're more than happy to offer them help and support. That's the end of my presentation. Thank you so much for being here with me for this watch party, and I hope you found it useful. I'll be staying around to answer questions for another 15 to 20 minutes, so there's still plenty of time for us to chat. Thank you to Flen Health for this evening's session. And if you would like information about Flamanal and Flamandral RT and how they work, or see the evidence on safety and effectiveness, then please visit their website. As I mentioned earlier, Flen have a number of hand hygiene tools to give away to staff who would find them helpful. And if you'd like to get hold of one, you just need to go to the website address on the screen now, which we'll also share with you in the comments. And thanks so much for watching. Have a good evening.